This is Krista. Welcome back to MadeToBeWhole. This week we are going to talk about the connection and similarities between tuberculosis and Lyme disease. Stay tuned.
MadeToBeWhole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on MadeToBeWhole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
Welcome back. So this week I'm going to talk about the best little book I have read in a very long time. It's called Everything is Tuberculosis. The subline is The History and Persistence of Our Deadliest Infection by John Green, who primarily wrote fiction prior to this, if I'm looking at his history correctly. It is absolutely fascinating and beautiful and compelling, and it is not a hard read. It's shy of 200 pages. Strongly recommend. But what I was struck by that I thought might be of interest to our listeners are the parallels between tuberculosis, not just medically, but historically, socially, socioeconomically, the parallels between that and Lyme disease, Bartonella, and other vector-borne infections. And one of the things that he discusses is the significant stigma that has faced tuberculosis patients. It's really interesting if you go back in history. At one time, tuberculosis, which was known by many names, but if you read about consumption in history, tuberculosis was known as consumption. And it was seen at one point as a disease of the wealthy or a disease of the artistic, intelligent person. And so the disease became almost romanticized. And I find fascinating that this standard of beauty that emerged at one point of the pale, waif-like looking female with rosy cheeks and red lips, that's the dying tuberculosis patient. And so that became kind of idealized in art because they're trying to, create beauty out of this awful tragedy. And so they would write about people with this ethereal beauty. And then you would read things about tips to how to make your cheeks rosy and your face pale and your lips red, so you can look like a dying tuberculosis patient. But think about that. Malnutrition became sexy because you were this thin, beautiful, waif-like person. So at one point then it became apparent that it was not somebody's artistic temperament that gave yield to this awful disease, but it was other things. It was living conditions. It was poverty. So then when we realized poverty and overcrowding, we give tuberculosis a different personality, and we treat people who get it as if they are dirty or less than. We're always trying to create ways and thought structures that make us immune from this tragedy we're trying to understand, I guess is how I would summarize it. And you see that a lot in the world of Lyme disease and vector-borne infections. And so there's some beautiful stories woven through here that I think you would find fascinating. I will leave that to your reading, but I'm going to read you some quotes and draw some parallels for you. So one of the things he says is really interesting. Most active tuberculosis illnesses occur within 2 years of infection, but sometimes the infection can lie dormant for decades before suddenly exploding into active disease. So science acknowledges this. It's well known that you can have latent TB. Okay, that's why we do screening. That's why healthcare workers, even without symptoms, have to get the tuberculosis skin test. And if it's positive, you have to have an x-ray, because we know there's such a thing as latent TB that even though it may not be active, still A, needs to be treated, B, can be doing damage, C, could have long-term health consequences. And D, now this is semi-controversial, shouldn't be, but can affect others. Now, TB is airborne. Lyme disease isn't airborne, but there is evidence, strong evidence that Lyme disease, Bartonella, Babesia, these other infections, that there may be sexual transmission, but that they definitely can be transmitted from mother to child. So these aren't illnesses that just afflict the affected individual that we're just going to let waste away in a corner somewhere because it's no one else's problem. There are downstream consequences. Now, he talks about what triggers a latent TB infection to become an active infection. Sometimes it's really clear. So, a compromised immune system is a big deal. But think of the parallels that we've talked about frequently on this podcast about things that compromise the immune system that can lead to a flare or a manifestation of vector-borne infections. So a compromised immune system from HIV. So certainly HIV is a huge TB risk factor, but other viruses can be immunocompromising. Malnutrition, and you can get malnutrition eating enough to not be underweight and living in a wealthy first world nation. You can still be malnourished. Stress, air pollution, all of these might, quote, trigger the disease into life. Another one he brings up that I harp on all the time, immunosuppressive medications to treat autoimmune diseases. If you watch television at all, every other commercial is for a medication. It seems like at least 9 times out of 10, it's for a medication that suppresses your immune system, because you would think psoriasis is like the greatest health plague in the world now. But by giving someone immunosuppressive medications, you can treat psoriasis and make a lot of money. It's the same thing for other diseases that are even more plaguing, but like ulcerative colitis, Crohn's, rheumatoid arthritis, lupus, all sorts of things. We give immunosuppressive medications, and then surprise, the immune system works even more poorly, and then these latent infections spring to life because the ability of the immune system shifts, and suddenly the body is overwhelmed by this load that it could previously take care of. Another thing I would throw into that category would be steroids. I do not think steroids are terrible medications. They can be life-saving in some conditions, but I think they need to be used with caution because they're immunosuppressive. And I have had patients who had a steroid injection, steroid treatment. And this whole idea that steroid injections are just local is the stupidest thing I've ever heard. Of course, it spreads everywhere else too. I mean, you may be putting it into a shoulder or a knee or a back, but there's not like cement barrier that's going to keep that from going to the rest of the body. And if I can give someone a shot of a steroid in their arm for systemic effects, don't sell me this line that the thing I put in your shoulder isn't going to affect other things. But that's a side rant. I've had plenty of people who have had steroids for other things to treat them, that then an infection kind of sprang to life because it was an immunosuppressive event. Surgery is an immunosuppressive event. Pregnancy is an immunosuppressive event. So I'm always thinking of infection when I listen to someone's history and they had an immunosuppressive event that led to a presentation, either initially or a flare, and a lot of other symptoms. The other thing that he says about tuberculosis that I think is fascinating, he calls it a near perfect human predator, in part because it moves very slowly. So it has an uncommonly slow growth rate. E. coli, very, very common, can double a number every 20 minutes in a lab. So super rapid replication. So infections take a lot longer to make people sick when they reproduce very, very slowly. The same thing goes for Lyme disease and Bartonella. So Bartonella reproduces every 24 hours, similar to tuberculosis. It shouldn't be a mystery to us that sometimes someone doesn't get sick initially, but yes, that tick bite they had 4 months or 4 years or 4 decades ago really could have been the start of what they're dealing with now. The other thing that tuberculosis does that is unique but not unique. So it takes a long time to build what he describes as its unusually fatty, thick cell wall, which is a formidable enemy to the immune system. White blood cells struggle to penetrate the cell wall and kill the bacteria from within. So we've talked about this again in the context of vector-borne infections, but a lot of diseases are stealth and they have their own survival mechanisms. I've talked at length about biofilms. You can have biofilms that are trapping disease, and your immune system, even just optimizing the immune system with or without the use of antibiotics, cannot penetrate the biofilm. We know that in Bartonella and Babesia, there are also fibrin deposits that are protecting that and making it harder to treat. So a few other lessons. He makes the comment, though, that the ill are treated as fundamentally other because the social order is frightened by what their frailty reveals about everyone else's. That's on page 56 of the book. I'm going to read it again. Either way, the ill are treated as fundamentally other because the social order is frightened by what their frailty reveals about everyone else's. I see this happen a lot in the context of chronic illness in general, especially with vector-borne infections, because I think if our system were to acknowledge that some people are suffering from chronic pain, from mental illness, from cognitive problems, because of the failure of our healthcare system to identify and to treat others. And if then we have to acknowledge that we have a healthcare system that profits off of chronic illness and not curing disease, that is disrupting a lot of apple carts. And that's really, really scary to people. And I understand that, but it's a conversation worth having. And gaslighting my patients and telling them that they're crazy because of their symptoms, but then they're also crazy if they get help and they find someone who can help. If you feel threatened by that, that's a problem. And maybe that would be a red flag. If somebody's asking me, should I look for another provider? There are no perfect providers in the world. None of us are perfect. We all have strengths. We all have weaknesses. But if somebody is threatened by your healing and is angry that you're getting better, I think that would be a red flag that it's time to look for someone else. You know, I had someone tell me the other day that they thanked their doctor for being like open to everything they were doing. And he told this individual, he said, well, what kind of doctor would I be if I was threatened by you getting well? I mean, of course I'm happy. I wish I had more answers for you, but I'm glad you're finding answers. And all of us should be happy for where people are finding healing and not say, oh, you know, people with chronic Lyme, they're just XYZ. There are a lot of contributing factors to chronic illness, and a lot of it comes down to sheer dumb luck, you know, because genes are luck of the draw. Environment is partly the luck of the draw. There are people who think they're living in a clean environment who are being exposed to mold and didn't realize. I mean, there's just like so many different things. The number of people who tell me, I have this story I've heard multiple times. I was perfectly healthy till I went on a beach vacation and was bit by sandflies or was exposed to some other bizarre thing. That person did nothing wrong. They did not choose disability. They did not choose pain. They did not choose anything that came with it. One of the other interesting things I think historically, though, is in the context of TB infections and how they've been treated historically, patients had to be very tightly controlled. So we had these monitoring surveillance systems, and they monitored where people lived. We monitored where they were, who they were with, medication. People used to be required to either be hospitalized for treatment to make sure that they were compliant, or to come get their medication in person regularly to make sure that they were compliant. And he talks about how the years of the sanitariums and everything, the way things were done, he said, most of all, the patient had to be controlled with their movements and choices and access to information severely limited. So the control over care dynamic is seen with many infections and diseases. And their choices were controlled by a health system that was wary of trusting the individual. And I think that's where we see so much kicked back now with some patients where there's been such excessive control that then you have a subsection of people who don't trust the medical system at all or anyone in it. And I would suggest trying to get in a frame of mind and finding someone that there can be some trust. I'm not saying blind obedience, everything that comes out of my mouth, don't question it. But if you have to question every single thing your provider says and you can't trust basic advice, don't waste your time and money. Like, go elsewhere. Go elsewhere. But you're going to be better off, even though we live in an information age. And yes, you have the internet, you have Chat GPT, which I've been told by some patients is their best friend. It's just a way to harvest information. You still need the help of people who know how to interpret the information, who have taken care of other people with similar things, who have seen how it plays out, and know that you're just getting limited bits of information. It's being organized, and it's a great tool. It's a great tool, but it's just a tool, and you can't let that take over. He goes back to why we have to treat obviously systemic problems, like the way we've dealt with TB, and I would posit Lyme disease and other vector-borne infections. Why do we treat obviously systemic problems as failures of individual morality? We always seem to find a way to blame the patient for non-compliance rather than blaming the structures of the social order that make compliance more difficult. And the term compliance itself reveals what this is really about deep down, which is systems of medical resource distribution exerting the same kind of control over TB patients in the 21st century that sanatoria exerted over TB patients in the 20th. That resonates with me so deeply. I do not use the word compliance in my charting. I never put down patient as non-compliant, because your body, your choice. I can give education and information and encouragement, but I say patient declined. Patient chooses not to because of this. Patient stopped due to this. Those words carry so much weight and blame, and they just reinforce the idea, well, you have to be compliant because the medical system is God and knows what's best for you. And if you're not compliant, I'm not going to take care of you as a patient. That's just like, ugh, I don't know. It makes me cringe. So, other barriers to care, again, drawing these Borrelia, Bartonella, Babesia, TB parallels, but he talks about, for many people living with TB, daily travel to a clinic proves complicated or impossible, because that's what some places are still requiring, especially when they're unwell. And think about that. Are we making unrealistic demands of people and saying they're not compliant because they can't get to their appointment, but they can't get to their appointment because they're so darn sick they can barely leave their house? And are we doing that to other chronically ill patients? And then he says, but such is the fear of antibiotic resistance and the distrust of patients that global health officials have this program they deem as necessary. But again, what could be more relevant to Borrelia, Bartonella, et cetera, than fear of antibiotic resistance and disrupt of patients? One of the reasons antibiotic resistance is an issue that I think is really, really important, he talks about it in context of TB here, and this is page 128 if you're ever reading along. Antibiotic resistance is complex and many tentacled beast. Countless factors from overprescription to antibiotic use in livestock have contributed to it. But considering the rise of multi-drug resistant tuberculosis in particular, it's important to note that we are in this mess first and foremost because we stopped trying to develop new treatments for tuberculosis. The real issue is not that TB is uncommonly good at selecting for resistance. The real problem is that in the 46 years between 1966 and 2012, we developed no new drugs to treat tuberculosis. The underinvestment in new classes of drugs to fight bacterial illnesses is the central cause of growing antibiotic resistance. I say amen to that. That absolutely applies when we're talking about Lyme disease, Bartonella. And when I have people who are told or who tell me that it's irresponsible to use antibiotics to treat these infections because antibiotic resistance is such a big, big thing, it is irresponsible to me to know that there is a disease and a potential cure and not to use it because I'm worried about something in the future when there's a problem right in front of me. So what you're essentially saying is we don't want anyone to die a sudden dramatic death from an antibiotic resistant infection. We would rather them die a slow, painful death from a treatable disease that we are going to choose not to treat, and thus make them dependent on the healthcare system and chronically ill and our best patients for life. There are absolutely the resources and the minds out there that we could have new and better antibiotics, but think about it. A new and better antibiotic, you're a patient for what? A month? A week? Maybe in the context of TB and some other things, a year, a couple of years, but you're not a patient for life. And if I'm just giving a Band-Aid to your pain or diabetes or mental health condition that is a consequence of infection, you are my customer for life. And I think we have to look at the cost incentives for drug development. So he talks about something in the history of testing for TB. So there are mobile x-ray machines that were used really, really widely at one point. But he's talking about in Sierra Leone, where he did a lot of his research. There was limited active case finding or preventative therapies in the early 2020s because there was so little money to fight TB. So you could diagnose people, but you didn't have the resources. Instead of x-ray machines fanning out across the country, many patients are still diagnosed via smear microscopy, which misses 50% of cases, especially early on in the disease. That's the exact scenario we're dealing with the two-tiered testing, the ELISA reflexing to the Western blot with Lyme disease. Very, very, very low sensitivity, especially in early disease. And then even when people get positive results, I can't tell you the number of people have come and they said, well, they said it was a false positive. So you're damned if you do and damned if you don't. If it's negative, they're like, see, this proves you don't have it. If it's positive, they say, it's a false positive. So we've got that same thing. So active case finding is used for tuberculosis, the idea of we're actively looking for cases, and it reduces tuberculosis by three mechanisms. First of all, early detection stops chains of infection. So that's important. Again, Lyme disease, the chain of infection may be smaller. I'm not going to go breathe on my neighbor and give it, but I gave it to my children. I really wish I would have known about Babesia and Bartonella when I was in high school and these symptoms started, and that this burden wouldn't have been passed on to them. Identifying patients before they become extremely sick allows for better overall outcomes. I think this is a really important discussion. It's a tricky, tricky thing because if somebody comes back, say positive for Borrelia, Bartonella, Rickettsia, whatever, and the argument is, but they're not sick, they don't have symptoms. It's a tricky balance because I do understand what you're saying, and you don't really want to poke the beast. But at the same time, if you can do something early on in the course of disease, especially if you know this is a new infection, there was a tick bite, there's a bullseye rash, well, but they don't feel that bad. Do it before they feel that bad. This is absolutely the time because it is so much easier earlier in the disease than later in the disease. And part of that is because the disease itself is easier to contain. But part of it is because of the damage that infections do when they're left. There's some really graphic descriptions of what tuberculosis does because these tubercles that are formed and the damage that it does, like literally, it can eat the lungs, it can eat other organs. And with these other infections, if you have impaired circulation to the brain, or if you have vascular inflammation because of infection that's ongoing, the longer those things happen, the worse outcomes you're going to have. So even though we may still say, yeah, we were able to get the disease, we may not be able to undo all of the damage. So the sooner, the better. And then the point is also made, the close contacts of infected people can be offered preventative therapy. again, no, this is not airborne like tuberculosis, but I think it's pretty wise if somebody comes to me and they're really sick and it turns out they have these infections and we treat them and their problems start to go away. If they have other family members with similar problems, it bears looking at. Now, again, this is not spread by kissing, sharing cups, living in the same house, breathing on someone, possibly through intercourse, possibly through childbirth, but then also look at the people you're closest to have been the same places you have. So if you have camped and hiked and farmed and cared for animals together, the likelihood of similar exposures is much, much higher. So breaking the cycle generationally, even though it's not quite the same mechanism of spread, I think the principle still applies. You know a lot of families where there's a lot of chronic health conditions that may have a shared infectious root. So some historical things we can learn about meds and dosing that I also think are really, really interesting in the context of what we do. So part of standard tuberculosis protocol is rifampin. Rifampin is a medication that is used for sometimes Borrelia, Bartonella, rickettsial illnesses, especially if somebody has a doxycycline allergy, you have to use rifampin. But he talks about the history of rifampin. So first of all, the argument that some medications are too costly. What makes something costly? He said, why is rifampin an expensive drug, or a variation of rifampin that they were talking about? He said, in the 1960s, it was challenging to produce in large quantities, but often our cost analyses assume incorrectly that a highly expensive drug seems to remain so. Today, rifampin costs less than half of what it did 40 years ago and is essential to TB care. At the time of its introduction, rifampin was tested in a 600 milligram once daily dose, which is still the standard dose. Not because that was believed to be the most effective dose, but because it was believed to be the cheapest dose that was still effective. And even today, we still prescribe 600 milligrams of rifampin, even though the drug costs less to produce, and it seems likely that higher doses would be more effective. Dr. Carol Mitnick, when he interviewed her, said, we've been underdosing with this drug for 50 years because we still base our cost analysis on how expensive it was to produce in the 60s. So again, what are some of our standards of care driven by? If something's a standard dose, why is it the standard dose? And being willing and curious as a patient and a provider to do things that are not standard. Sometimes that's dosing higher, sometimes that's dosing lower. That drives some people crazy, that some people, I will start on 50 milligrams of doxycycline once a day because that's what they can handle. Because if I give them 100 milligrams twice a day, they will not be able to tolerate it. But there are some individuals who, based on size, gender, symptoms, everything, they need 200 milligrams twice a day. The right drug, the right dose, and the right duration are a big, big deal. Other little caveats that I think are parallels that I'll throw out here. He talks about untreated HIV lowering resistance to infection. Really, really important. Obviously, Epstein-Barr is not as devastating than HIV, but the idea that chronic viral illnesses hurt immune function is a true principle that applies. So that's why I like to also screen for Epstein-Barr, cytomegalovirus, HHV6, other viral things that can be contributing. TB he describes, I think, really beautifully as an illness of weak healthcare systems that weakens healthcare systems. It's an illness of malnutrition that worsens malnutrition. And it's an illness of the stigmatized that worsens stigmatization. In the face of all this, it's easy to despair. TB or other infections like Lyme doesn't just flow through the meandering river of injustice. TB broadens and deepens that river. It is not enough just to have willpower. He says in the chapter 20, Hail Mary, survival is not primarily an act of individual will, of course. It's an act of collective will. We have to do our part, not just for ourselves as patients and advocate, but I think families, communities, and healthcare systems need to recognize that it's our failure to diagnose and treat Lyme, Bartonella, Babesia, other vector-borne infections. It's our failure to diagnose and treat that is what's really expensive. And that's what the failure is. If we did these things early on, there would be so much savings, so much increased productivity, so much decreased disability. It would be a virtuous cycle. It would be excellent for everyone around. And it's a hard balance, I think, as a provider and just as a human, to be aware and cognizant of injustices and inequities, but to not be overwhelmed or consumed by them, because ultimately you can take care of what's in your sphere of influence. You have to start by taking care of your health and your family's health. Like, that has to be your first priority. And then you look from there. If you can help someone else maybe get the right testing and treatment, and they can go on to take care of their family and help someone else, those little individual grassroots efforts do matter. I know there's a lot of excitement about conversations that are happening with HHS around Lyme disease and other things. I think it's good that there are conversations that are finally happening. I'm always glad for more information, but don't wait on the healthcare system to catch up to take steps to improve your health. You don't have control over everything, but you have control over something. And ultimately, you are the driver of hope. So remember to have hope and share it with others, because you were made to be whole.
Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.